I think we can start. Okay.
Okay, sir.
Okay. So, good morning, everyone. As usual, we'll start the program. I will open the screen, share the screen. Okay. The first case, as usual, will be a short case. Then we'll go for the long case. Is my screen visible to you all?
Yes, sir.
Okay. Now, this is a story of a 56-year-old man. He developed 2 days back headache and went to the local doctor who detected high BP and was referred to the cardiologist. Cardiologist examined and put him on antihypertensive C medication. Next day, when he got up, he noticed that he has some difficulty in walking, in that his right foot would go into inversion while walking, and chapels get slipped off, and then that's why he came to the OPD on that one day later. This is the video of the patient. His lips were a normal tone or normal down. There is no incoordination. Tone was okay in here. Immediate fasting in the right foot, we don't know whether we are holding it or not. I am not sure. Our oxygen muscles were normal. Weaknesses noticed, mild weaknesses, right hand, 4 plus power, to overcome the muscular suppression. Inversion was also weak. Inversion was weak. This inversion that is found on the right. Inversion on the right side was also weak. Also weak. Suppression, inversion was weak. Breathing was weak. And vasculitis lungs are also weak. It is weak on the right. Hip abduction was normal. Suppressors were diminished by that. And it also. And with reinforcement, just reducing. Same from the other side as well. Under was indefinite. And the upgoing or downgoing. Patients was grossly normal, including the Okay. So an examination, tone is normal in both the lower limbs. Power, weakness of the right dorsiflexus, inverters, EHL, and flexor pollicis. Flexor hallucis, not pollicis, hallucis longus. Detail both knee ejects and ankle ejects were absent. Tandas indefinite. sensory normal, SLR negative, gait almost normal, mild foot drop, something like that on the right side. So what do you think the patient is likely to be having? Possibilities?
Sir, good morning. It's most likely
Yeah.
cortical
Yeah,
events, cortical vascular.
vascular event cortical, right? Perfectly right. Do you want to give any significance for the absent reflexes, the knee and ankle at bilateral?
No, sir. No.
Because it was confined to right side, it would have given significance. But present bilaterally in this patient may be most likely unrelated. So what do you want now?
MRI.
MRI. Okay. This is the MRI flare. This is the uppermost cut of flare sequence. The MRI diffusion. Okay. What do you want now?
Nerve conduction.
Pardon?
Nerve
Vessel,
conduction.
vascular imaging. Vascular imaging.
Okay, do vascular imaging, but we have to demonstrate an infarct. No?
Since it's a small confined area, so this must have been missed in the first MR. So we'll repeat the MRI.
Repeat MRI was to be done. Okay. But actually the point was that you have to do the uppermost cut because here the weakness was confined only to the right foot. So very often when you do the routine MRI, they may miss the uppermost cut. So here what I did was I went back again, I for diffusion. See the uppermost cut, you can make out the clear infarct, the uppermost cut, the diffusion. So that's only point I want. This also another infarct here also. Again, the ACA territory. The point is that many a time when you get an MRI, the sequence they take will be, especially diffusion, the width is high. So unless you ask for specifically, you go and take the uppermost cut, you will miss the lesion because it's confined only to the right foot. So lesion you expect only will be in the leg foot area of the motor hormone cortex. Now that's the only point I wanted to make here. You're all right. This is a short case. Now we'll go for the real. This is a cortical foot drop, AC in front. Now we'll go to the next case. Okay, shall we go to the next case now? Any questions? I think it's straightforward. I think we'll go to the question. Okay.
Yes, sir.
Sir, why should they avoid the uppermost cut? So, I mean, is it?
It's not a usual routine, no? The MRI, if you just send for MRI, they take only some usual cuts. They may not concentrate the uppermost cut, they may not take unless it's specifically asked for. And it'll be a small, it'll be a thin cut. Otherwise, again, you will miss the infarct. Usual 10 millimeter cut and all, you'll miss it. So you have to ask for it specifically. Same thing will occur also with the brainstem infarct. You can a patient coming with MLF lesion or something like that, or a midbrain lesion, a small infarct you miss unless you specifically ask for coronal cut of that diffusion coronal. Again, routinely they don't do coronal diffusion. Specific as for you have to do coronal diffusion. Otherwise, you miss a infarct of the brainstem. Time and again, I have seen this.
Sir, can I ask you one question?
Yeah, please, sir, please.
Sir, I'm Dr. Bhavin from Baroda.
Yeah, please.
Sir, we expect some plantar to be extensor in this patient.
Yeah,
Isn't
right.
it?
Yeah.
Even in patient of cortical foot drop, we expect extensor plantar.
Right. We are perfectly right. We expect an expect an outgoing plantar on the right side, but very often in pyramidal lesion, you may not get a quick plantar. You have to base a diagnosis not only on all the, you do not expect all the findings of pyramidal lesion, you do not expect. So that is why this case has been brought. There is some features of an element like absent reflexes and weak, but you must remember that the weakness was not confined to a root or a nerve distribution. So you have to take the positive as well as negative aspect. What is the positive aspect? Acute onset is hypertensive, then you look likely to be infarct. But the negative aspect is that The weakness we got was in the dorsiflexus, plantar plexus, flexor hallucis longus, and extensor hallucis longus. That pattern, if you want to explain by a neuropathy, you can't explain it unless you think of a sciatic nerve involvement. Okay.
Okay. Yeah.
Second thing, if you think of radiculopathy, there is no involvement of the proximal muscles in this patient. The hip abductors will be not normal. So that point, we should make a thing that is unlikely to be element. But plantar aspect may need not be there, especially if it was absent bilaterally. So probably may have, and patient might have some, maybe constitutionally some people may not have been plantar. If it is absent only on the right side, sorry, it is flexor on the left side, not elicited on the right side, again, you can take it as significant. But it was indefinite on both sides. So just like absent reflexes bilaterally, that indefinite plantar need not be given significance. You have to base your diagnosis on other clinical parameters. Okay. Shall I go to the next page?
Yes, sir.
Yeah. Now, this is a very interesting person. A 67-year-old diabetic. He presented this to back pain 3 weeks back. It is not radiating, only confined to the lower back, not lower upper back, for which you went to the doctor. You took 3 injections from the local hospital, and then pain partially subsided. The real problem started 2 weeks back. That is 1 week after the lower back ache. He noticed numbness of the left foot, followed 2 days later by loosening of the chapels on the left foot. 1 week later, he noticed difficulty in buttoning his shirt, sorry for the spelling, but shirt with the left hand, which progressed in 5 days so much so he was unable to press button with his left thumb, which he was able to do on the day prior. He was very clear that there is progress. I repeatedly asked, was it along with the left foot? He said, no, it foot occurs 2 weeks back. This having problem with 1 week back later. And that too, the weakness of the hand progressed. Initially, he was able to do only my difficulty was only for doing mild things. But later on, he said, how he found was he's a diabetic. No, he was taking the syringe and needle with the left hand. He said he was not able to press with the thumb on the day prior, which was able to do 4 days, 2 to 3 days prior. For the last 1 day, he noticed numbness of the right foot as well, but there was no weakness of the right foot. So this is the story. Okay. There's no history of weakness of the right upper limb or right lower limb. This is the video of the patient. Ocular movements are normal. There is no patient weakness or alien movement. Tone was normal in the left upper limb and right upper limb. Deltoid was normal bilaterally. Biceps normal. Triceps normal. This section is normal. That's also normal on the left side. This section is normal. That's normal. But the finger essentially grossly weak on the left side. The extensor pollicis longus and brevis are also weak. He could not extend the finger, but he was able to normal in the right side. Extensor pollicis longus and brevis is normal, but both are weak on the left side. See, it was weak, and also flexor pollicis brevis was also weak.
ഇത് മാത്രം ഇങ്ങനെ ആക്കാൻ നോക്കിക്കേ ഇല്ല അതും പറ്റുന്നില്ല ഇനി ഇത് അകത്തോട്ട് മടക്കി
That is normal on the right side.
മടങ്ങാതെ ഇങ്ങനെ കൊണ്ടുപോകാം. അതെ, ഇനി വിരൽ മടക്കിക്ക്.
Finger press is normal on the right side. It's
അതിൽ
also normal on the left side.
പിടിച്ചോ പിടിച്ചോ. ഇത് മടക്കി ഇങ്ങനെ പിടിക്ക്.
But the maximum pressure,
മാക്സിമം പിടിച്ചോ.
it's very good power. All finger presses.
ഇങ്ങനെ ഇരിക്കണം.
This flexion was also normal.
ഇനി കൈ ഇങ്ങനെ പിടിച്ചോ, ഇങ്ങനെ പിടിച്ച്.
Brachioradial is normal.
ഈ കൈ ഇങ്ങനെ മേലെ അകത്തി പിടിക്കേ.
The finger abductors were weak on the left side.
അകന്നിരിക്കണേ. അടുപ്പിക്കാൻ
But
സമ്മതിക്കരുത്.
all small muscles are
അകന്നിരിക്കണം അപ്പച്ച. ഇതകത്തിക്കാൻ നോക്കിക്കേ. ഇനി മടക്ക്. നൂർത്തെ.
interosseous were weak on the left side, normal on the right side. Common sense, he cannot even hold the
അടുപ്പിക്കാൻ പറ്റില്ല.
that is again severely weak on the cannot even
ആക്കാൻ നോക്കിക്കേ.
keep it. It's all severely.
ഇങ്ങനെ ആക്കിയിട്ട്.
The lower limb tone was normal.
ബലം കൊടുക്കരുത്. ബലം കൊടുക്കരുത്. ശരി, ഇനി ഇവിടെ പിടിച്ചോ. ഈ കാല് നേരെ പോകും.
Deflection normal on the right side. It's also normal on the left side. Initially not cooperate, made it. It's normal on the
തെറ്റിപ്പോകും. മുട്ട് മടക്കിക്കേ. ചവിട്ടി നൂർത്തെ.
knee extension normal on the right side. It's also normal on the
ഇത് ചവിട്ടി മാറ്റണ്ടേ. തള്ളി അങ്ങ് മാറ്റണം. വെരി ഗുഡ്. അത് സമ്മതിക്കല്ലേ.
Concentration normal on the right side, but that is weak on the left side. That is weak on the. That is weak on.
ഇത് പൊക്കിക്കേ. അല്ല, ഈ തള്ളവരുടെ മുകളിലോട്ട് അത് ഇങ്ങോട്ട് പിടിച്ചോ. മുകളിലോട്ട് അത് അതേപോലെ ഇത് പിടിച്ചേ.
EHL was weak on the left side.
ഇനി ചവിട്ടിക്ക് എന്റെ കയ്യിൽ.
Plantar flexion normal bilateral.
ഇത് ചവിട്ട്. ശരി, ഇനി ഈ കാല് ഇങ്ങനെ ഇരിക്കണം.
Inversion was normal on both sides.
ഇല്ലേ, അതേ ഇങ്ങനെ പിടിച്ചോ. അതേപോലെ ഇത് പിടിച്ചോ. അങ്ങനെ പിടിച്ചോ. ഇടല്ലേ, പിടിച്ചോ.
We can be convincing. Inversion was weak on the left side, definitely. That is definitely.
അങ്ങനെയല്ല, എനിക്ക് ഇങ്ങനെ അങ്ങനെ ഇരിക്കണേ.
That is weak.
ഇത് വിരല് മടക്കിക്ക്. മടക്കി
Flexor point is was normal bilateral.
ഇത് പിടിച്ചോ വെച്ചാ.
Flexor had
കാലകത്തി പിടിച്ചേ. അടുപ്പിക്കാൻ
protection normal.
മതി. തള്ളിപ്പിടി. അത് വരെ.
Hip extension normal bilateral.
തള്ളിപ്പിടി. മതി. ഈ മുട്ടൊന്ന് മടക്കി. ഇത് മടക്കിക്ക്. ഇത് ആദ്യം
Knee flexion is also normal.
ഓർക്കാൻ സമ്മതിക്കില്ല. വിട്ടേ. ഇത് മടക്കിക്ക്. വിട്ടോ.
From the reflexes, biceps and supinator just sensitive on the right side.
കയ്യിലോട്ട് കിടക്കുക. അങ്ങനെ തന്നെ.
It is slightly brisk around, very sensitive on the left side.
അത് കൊടുക്കല്ലേ.
Supinator also very sensitive. Just right side, left side very sensitive. Right side just sensitive. Biceps is absent bilaterally. Weakness is mainly in the wrist and the finger extension on the left side. Biceps absent.
പകുതി അങ്ങനെ ഇരിക്കട്ടെ.
Finger flexion is also absent bilaterally.
മുട്ട് മടക്കിക്ക്.
Come to the knee jerk, normal on the right side, 1+ on the right side, 2+ on the left side.
ഞാൻ പറയുമ്പോഴേ കൈ മുറുക്കി പിടിക്കണേ. രണ്ട് കൈയുമേ മാക്സിമം പിടിക്കാൻ നോക്കേ. മുറുക്കി പിടിച്ചോ. വിട്ടോ. അങ്ങനെ കൊടുക്കാതെ.
Angle jerk is absent bilateral.
മുറുക്കി പിടിച്ചേ. അച്ഛൻ ഡയബറ്റിക് ആണോ? ശരി, ഒരു മിനിറ്റ് ചുമ്മാ ഇട്ടാൽ മതി.
Under indefinite flexor bilateral.
ഇതും ഒരേപോലെയാണ്. കുറവോ കൂടുതലോ? കുറവ്.
He says mild decrease in the pain on the left side, not very convincing.
ഇതും തമ്മിലോ? കറക്റ്റ് അങ്ങനെ പറയാം.
It's a dorsal aspect, it is less on the left side.
ഇതും ഇതും തമ്മിലോ? കറക്റ്റ്. ശരി. ഇനി കൈ ശ്രദ്ധിച്ചിരിക്കണേ. ഈ കുത്തുന്നതും ഇതും തമ്മിലോ?
No difference in the pain in the upper limb.
ഒരേപോലെ. ഇതും ഇതും ഒന്നുകൂടെ വെച്ചേരാം. ഇതും ഇതും കറക്റ്റ്. കയ്യിൽ മടന്നിരിക്കുന്നു. ഈ കുത്തുന്നതും ഇതും കറക്റ്റ്. ഈ കുത്തുന്നതും ഇതും തമ്മിലോ? കറക്റ്റ് തന്നെ. ശരി.
It's an equal both bilaterally.
പറഞ്ഞോ? ഒന്നേ തണ്ണിക്ക് എനിക്ക് കേൾക്കണേ.
The sensation was also normal. It's able to feel the essential left foot as well.
ഇപ്പോഴുണ്ടോ?
Vibration normal in the thumb and electrical in both hands.
ഇപ്പോഴേ ഉണ്ട്.
The feet, the toes, it was,
ഇപ്പോഴേ
he said yes.
ഇല്ലെങ്കിലെന്ന് പറഞ്ഞാൽ മതി.
Maybe mildly decrease on the both sides. Sometimes he said yes, sometimes it's not there.
ഇപ്പോഴേ ശരി. ഇനി അടുത്തത്
Joint sense normal in the upper limb, absent over the toes.
ശരി. ഈ ചെറുവരലി പറയണം. ഇപ്പം എങ്ങനെ? ഇപ്പോഴേ 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 ഇപ്പോഴേ
It correctly. The thumb also sets it correctly.
ഇപ്പോഴേ 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 മോളെന്ന് പറഞ്ഞാലും മതി. ഇപ്പോഴോ ഇപ്പോഴേ ഇപ്പോഴേ
He said he's not able to say bed sense.
ഇപ്പോഴേ 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 ഇപ്പോഴേ
LR was negative. It depends on the gait of the patient. This is mildly positive. Is it absent JPS bilaterally or both two?
എൻ്റെ കൈ പിടിച്ചു. പിടിച്ചിട്ട് ഞാൻ ഇന്ന് നോക്കും.
He couldn't walk on heel on the left side, but he could walk on toes. Gait aspect of the drop on the right side. Sorry, left side.
സ്പീഡ് നടന്നേച്ചാ നിങ്ങൾ സ്പീഡ് നടന്നു സ്പീഡ് നടക്കും സ്പീഡ് നടന്നു ഫാസ്റ്റ് നടന്നു.
So that's the story. On examine some of the finding. Cranialness normal, motor tone both normal, both upper and lower limbs. Power right upper limb all normal. Left upper limb, weakness of left finger extensors, extensor pollicis longus, and extensor pollicis brevis as well. Flexor pollicis longus, and all small muscles of the left hand, thenar, hyperthenar, interossei, and adductor pollicis. The lower limb, right lower limb normal, left lower limb, weakness of left dorsiflexor angle, evertus, and EHM. These are the muscles weak. Deep reflexes, upper limb biceps supinated normal on the right side, slightly brisk on the left side. Triceps absent bilaterally, finger flexion absent bilaterally. Lower limb, right knee jack is 1 plus, left knee jack is 2 plus, both angle jack absent. Plantar flexor bilaterally. Sensory absent JPS both toes. Rhombus is mildly positive. Gait would drop on the left side. These are the findings. So where is your localization and likely possibility?
Sir, it's more likely in the peripheral nerves, something like a mononeuritis multiplex involved in the left contour nerve, as well as the left posterior interosseous and anterior interosseous nerve.
Mostly but small muscles are also weak. Introsci are also weak.
That could be because once there is a weakness of the finger extensions, so it may be difficult to
But-
examine the finger. That maybe that's
Yeah,
what I.
that's why Umar, you are correct. That's why put the hands onto the table. Small muscles are also weak.
So in that case, the ulnar may also be affected.
Can be affected, yeah. Multiple nerves involved.
Yes, sir.
Okay. Yeah. Any other possibility from what could be a possibility?
Anterior
Duration is
onset.
only 3 weeks.
Sir.
Anterior onset disease, but yeah, the impaired joint sense could be due to the unrelated diabetes mellitus on the feet. That's
Yes, sir.
yeah, good possibility. Early motor. But
Because
the
sensory
anterior
is
onset involving.
because
Yeah, yeah, agree
despite
with you. Yeah.
motor weakness in the left hand, the sensory involvement is minimal, which usually in ulnar nerve or medial nerve we cannot explain with the absent sensory involvement and the total weakness of the small muscles of the hand.
Correct, perfectly right. That I agree with you. Only odd point is that what it's only short duration. He's very definite about it. 2 weeks. Then 2 weeks left left lower limb, left foot, and 1 week left hand. And
Sir, was he
this is
having any
very
bladder
progress.
symptoms?
No bladder, no bladder. No bladder, no painless symptom, no headache, no sensory complaint in the upper limb.
Okay.
It's a diabetic. Any other possibility you want to keep? Can be developing GBS.
Diabetic plexopathy, sir, lower plexopathy, lower brachial.
But but again, still part of both lower limb of plexopathy is it very common?
Not, sir,
No
not
pain.
very common.
No pain.
Motor roots.
Only back pain. No pain in the
Can
limb.
it be motor roots?
Second thing, can be developing GBS. GBS can be purely motor. It completes a paresthesia recently that orthopedic department.
But reflexes
like a
are
man.
preserved, sir, the lower upper limb. Reflexes are
Yeah, but reflexes, in
present.
fact, little more brisk on the left side if at all. But the point
Yes.
is that the affected muscle roots were the lower roots. The triceps was absent, finger flexion was absent. Now, the affected segment was what?
Yes, sir.
Finger extensors and small muscles. That root distribution or nerve distribution, whatever it is, that reflex was absent.
In that case, lower limb, how to explain, sir? The EHL is weak, but the knee extensors is 5/5 power, and
Sir, can
only
we
the
think about
levators and the dorsiflexus being weak with L4, L5 involvement is usually
sir,
odd.
can we think about two pathologies together, because he's already diabetic having pre-existing neuropathy, and now some selective involvement of the left half of the body more than the right one, some cervical pathology which is just shaping up gradually.
It is
Thanks,
very
there's
unlikely
connection.
to have a unilateral affection with the spinal cord with this sort of patchy lesion as well as with a Guillain-Barré. So I would still put something like a mononeuritis multiplex, probably with underlying diabetes.
Sir's connection has lost, probably.
Yes, I think so.
Hello, are you able to see me? Hear me?
Yes,
Yes, sir.
yes, sir. Yes.
Yeah,
Sir, can it be something like a month, sir?
Amman is a possible. That's the thing, something akin to a CADP like thing, no? I mean, not CADP, 8 GBS like thing. Yeah, that's a possibility. Amman like thing. Developing phase, correct.
But one side of the body?
That's again, there are many things against in this patient. That will come to that. But you know, in the developing phase, it may start on one side. Within few days, it may can go to the other side. That's a problem. Suppose it's a long duration confined to one side. Agree with you. That's unlikely for an Amman or GPS. Okay, I will explain one.
He's a diabetic.
He's a diabetic.
So why can't it be a stroke with a diabetic neuropathy?
Diabetic is not neuropathy. It's not confined to the peripheral. Neuropathy is bilateral. No, it should be mononeuritis multiplex. That's a
Mononeuritis multiplex with the.
that's a possibility we are keeping. Yeah, that's a possibility we are keeping.
It's a stroke on the left side.
Yeah, but the only point is that, as Bindu was telling, there was no sensory in the nerve distribution. Only the motor part is affected. So neuropathy which affecting the motor part is more likely to be something like a demyelinating neuropathy, where you know ADP and Amman, they only confine to the motor part. Sensory is less affected. Only symptom may be the only sensory. Findings may not be. Anyway, let us see. Are you able to see my screen now?
Yes.
Yeah.
Yes, sir.
Now, what do you want now?
Nerve connection.
Now let us see the nerve conduction. This is the nerve conduction. Enlarge and see you. On the left side, the CMAP amplitude is decreased. And look at the velocity. Sorry. The velocity on the right peroneal nerve is 37 and the left tibial is 37. What do you think about this MR and NCB finding?
Bilateral.
Yeah, it's bilateral there. But my question is it demyelination? It is not.
Mixed.
Yeah, you have to think this is something like an axonopathy on the left side. On the right side of the right common peroneal, this the lady checked again. This particular lady checked again. Can it go with demyelination? No. To call demyelination, it should be less than 36 because at least more than 20% of the lower limit of normal. If you conduct the lower limit, if you take 44 as a lower limit, it should be at least 36. Only if it's less than 36, you can put. So borderline. We are not very sure about it. Now let us see the other nerves as well. So this is the criteria for demyelination that I will skip. Look at the sensory in this patient. See, the onset latency is normal, but the peak latency is increased. So what does it suggest? The sensory potential, the onset latency, yeah, it's a suggestive of some dispersion of the sensory potential, some dispersion, but again, not very convincing. Demyelination confined only to middle segment, not definitely the distal segment is little odd, but anyway, that possibility has to be kept in mind. Not a very strong indicator demyelination, but a possibility, suggestion, because some suggestion of a dispersion of the potential is there because of the proximal latency on the onset latency and peak latency. That means from the onset of the potential, take the peak mean take longer time. That means the potential has to be slightly dispersed. But the onset latency is normal. So that means the velocity part is normal. Only thing is that the fibers are not conducting equally. So maybe normal amplitude, so I say mild dispersion, mild degree of demyelination. Okay, let's look at the FA. Left median, ulnar mean, all FA latencies are prolonged. Right peroneal is absent. As expected because we don't expect an FA on the left side. because the potential is low. But on the upper limb, on both sides, FA latency is prolonged. Okay. So what do you think now?
Demanding.
Emanation. So, but are you happy now? Let's look at the video once again. There is something which is very disturbing from the very beginning. Is it not? No. You're all, something is disturbing you all, I'm sure, because you are not happy to diagnose GBS, you're not able to diagnose mononeurous multiplex, it's not there. Let the video once again. I'll show the video part. That is why meticulous clinical examination is very, very crucial in this patient, in every patient, in fact.
പിടിക്കണം എത്രത്തോളം ഉണ്ടെന്ന് അറിയാൻ വേണ്ടി
The
പിടിച്ചോ
exercise,
പറ്റും പിടിച്ചോ അങ്ങനെ പിടിച്ചോ ഇത് മുകളിലോട്ട് പിടിച്ചോ
you only should develop
അതേമാതിരി ഇത് പിടിക്കാൻ ശ്രമിച്ചു
the finger exercises will be very
ശ്രമിച്ചാൽ മതി ഇങ്ങനെ ആക്കാൻ നോക്ക് എത്രയേ ഉള്ളൂ പൊക്കാൻ നോക്ക് ഇനി ഈ വരും ഇത് പിടിച്ചോണ്ട്
the extension of the finger is thumb is
കൈയുടെ
very
പൊക്കി പിടിച്ച് പൊക്കിക്ക് പറ്റുന്നില്ല ഇത് മുകളിലോട്ടാക്ക് ഇല്ല ഇത് മുകളിലോട്ടാക്ക്
normal on the right side.
അതേമാതിരി ഈ തള്ളവരിൽ ഇങ്ങനെ മടക്കിക്ക്
The point I wanted to say is
ഇത്
Policy's longest is in the left leg.
ഇത്രയേ ഉള്ളൂ മടക്കകത്തോട്ട്
But all other finger flexes are not.
ഏറ്റവും മടങ്ങാൻ ഇങ്ങനെ കൊണ്ടുവരാൻ പറ്റും ഞാൻ ധൃതി പിടിക്കല്ല ഏറ്റവും മടങ്ങി ഇങ്ങനെ ഇത് മാത്രം ഇങ്ങനെ അകത്തോട്ട്
That is normal on the right side.
മടങ്ങാതെ അറ്റം മടങ്ങാതെ ഇങ്ങനെ കൊണ്ടുപോകാം അത് ഇനി വിരൽ മടക്കിക്ക്
That is normal bilaterally. That is finger flexes are normal.
പിടിച്ചോ പിടിച്ചോ മടക്കി ഇങ്ങനെ പിടിക്ക് പിടിച്ചോ അങ്ങനെ മാക്സിമം പിടിച്ചോ
Okay, this is the video. That is the video. Okay, the rest flexes is also known. Okay. Now, from this video, what is there anything with disturbing you?
So we have to think of a cortical lesion. Everything is we can explain with a single lesion. Should be in the cortex.
Yeah, the problem is what you said is his thumb is maximally affected. Come to consider a nerve lesion, ulnar nerve, nerve lesion to account for the flexor pollicis longus. You have to think of anterior nerve as initially or Umar thought. But the point is that if anterior nerve is affected, how can you explain the weakness of the thenar muscle? Because that you can't explain. Moreover, you expect weakness of the finger flexors. So that means if it has to be a median nerve involvement, we want to explain the weakness of the flexor pollicis longus and the small thenar muscles. You expect a proper median nerve. In that situation, you expect the finger flexors to be strong, it will be weak also, but that is quite normal. That's not fitting with the nerve involvement. That's an odd point of that thing. If you think of it, say there's I mentioned again, a field due to affection of the median nerve, why the finger flexors has failed. If it is due to anterior involvement, why is the thenar but affected? So it's not fitting with either a median nerve or either a anterior nerve. Now, it could be a radiculopathy then. Again, not possible because if flexor pollicis longus is due to the C8 radiculopathy, which is the root value for that, why other muscles supply C8, other finger flexors also spared? That also we expect other finger flexors, even wrist flexor also we expect to be involved. Like flexor carpi ulnar is supplied by that C8. So it's not fitting with an element pattern. That's quite odd. But in GBS, it's not necessarily fitting with the pattern. Second thing, any other odd point you noticed, his left biceps was brisk and left knee jack was brisk. Correct?
Yes.
Yeah, computer. That also was standing out an odd point. His weakness is moreover, his weakness is confined to one side of the body. So what are the investigations you need now?
Neuroimaging.
MRI brain.
You want
Cervical spine.
brain
MRI.
or cervical?
Cervical spine MRI.
In fact, I want both. Because it can be anywhere. It can be the cervical cord, it can be the brain as well. The only odd point for the brain is that it's
Facial is
totally spared. That's an odd point, but many patients can present only with hand. I've shown previously weakness only thumb in a person with this thing.
So the
Okay,
problem against stroke is of longer duration, be 2 weeks, it's
yeah,
still progressing. So you have to implicate something else other than a
yeah, yeah. It's not a stroke at all because the total duration is nearly 2 weeks now. But then that is when the story is now started now. He's an old case of renal cell carcinoma. Because in fact, what happened was this is a father, the children who bought the parent did not divulge any of these things to me. He just showed them because they did not tell him that, tell their father that he's having a malignancy. He does not want him to know that thing. So he hid every details from the father. So when I was examining the father, these people did not tell anything. When I finished the investigation, everything, then they are coming with the record. Then they showed me that this is he was having a renal cell carcinoma. Then this is CT scan. In fact, they came with the CT scan. It showed me only later. He's got edema on both hemispheres with some hypertension lesion on the right side. And there's some hyperdensity in the cerebellum also. Did you see that? Multiplies hyperdensity. Well, let's say the MRI of the brain. See, straight from lower down onwards, it's got hyperdensity in the pyramid on the right side, in the pons on the right half of the pons, and also another nodular lesion in the CP angle involved in the eighth nerve on the right side. Again, in the midbrain, bilaterally, more on the right side. Left internal capsule, thalamic region. Both hemispheres, more on the right side. And you can see some heterogeneous hyperintense lesion adjoining the hyperintense edema. Here and one here. This is the prior sequence. Multiple areas of hyperintensity. There's no diffusion restriction for the lesion. There's only one area of blooming, all other areas are not blooming. And this you can clearly make out the mass outside the brain as well. And you can see the enhancement pattern, multiple areas of hyperintensity. And probably this region is for his lower limb weakness. This is for his upper limb weakness. Just 1 minute. It's not I've been called from the hospital. It's 1 minute. Hello, you say? In ability, abnormal behavior, irrelevant operator one another. When they reduce slowing, then cortisol. Correct. As you said, yes. There's a matter. And a meeting in another you can see. Do. Just in another second. Just another second. So, what do you think? It's a multiple. Am I audible to you?
yes, sir.
Yeah. So, multiple metastasis from brain cell carcinoma. That is the diagnosis. See
Sir,
how.
in that case, the left plantar flexors are normal. So that's the point.
Now I'll come to just 1 minute. No, the problem is left foot drop, most likely due to metastasis itself. But possibility of Joseph in the patient series or no? Okay. Because his component amplitude was low. But personally, I don't think it is due to that. Maybe due to the metastasis itself. Because the time, the evolution of the illness, if you take into consideration, 1 week, 2 weeks back started, then 1 week it occurred. Why should a mononeuropathy occur along with the present illness itself? So logically, it does not seem to be correct. Okay. Moreover, there is no sensory in the distribution of the component.
So was the cervical MRI done?
Cervical MRI was not done.
Sir, then how to explain the triceps reflex absent in both the hands?
So they are all unrelated problems. Sometimes this is
Okay.
just the previous case when doctor was asked why the plantar was not upgoing. See, he has got clear pyramidal lesion, so the plantar is downgoing.
Okay.
So may not get. So in cortical lesions, the infarct or whatever it is, confined to the cortical lesion, the weakness may be confined to certain muscles only. It's called cortical foot drop. They affect only the dorsiflexus and equators, mimicking peroneal nerve palsy. Sometimes it can mimic a radial nerve palsy because the weakness may be only in the finger exercise. So this possibility has to be kept in mind cortical lesion.
Sir, what could be the cause for his low backache? Because that
He had
may be part of
metastasis.
it.
No, he was having metastasis in the back also, the spine also. But there's no cervical lesion.
The upper, sir, that medullary lesion,
Yeah,
that also can explain this thing, no, sir?
yeah, it could be.
The cruciate paralysis kind of, he had some right upper.
No, that's something the right upper limb. Right upper limb was normal.
No,
Right,
sir, the lesion is in the right cervical medullary junction.
yeah, right.
So his first symptom was left upper limb numbness and followed by left lower limb numbness.
No, left foot followed by left upper limb doesn't matter, but still that's little odd because in a pyramidal lesion, it is more likely as a pyramid lesion, not pyramid lesion in not a medulla. The involvement is more extensive because the fibers are together. It will likely to involve upper and lower limb together and be more extensive involvement rather than confined to the hand or foot. You got the point. In cortical lesion, you get pyramidal lesion. The weakness confined only to the hand or confined only to the foot. Okay, but in a pyramid lesion or a crus-cerebral lesions or spinal cord lesions, only confined to the hand, only foot is very, very uncommon because the pyramidal fibers are
Okay, sir.
grouped together, is traveling in one single large bundle. That the area representing the cortex, the different areas represented in the cortex are different or extensive. So selective involvement and moreover, the thumb hand involved areas maximally represented in the cortex.
So the hand weakness also could be explained with a cortical lesion, like
It is.
because the sensory was not involved.
Yeah, it is with the cortex.
Yes.
Everything is with the cortical lesion. The lower limb weakness and the left upper limb weakness is all due to the cortical lesion.
So is there any bleed also in those lesions?
No, because renal cell carcinoma is one where the metastasis can have bleeding. But the SWA showed blooming only in one area in the cerebellum. The other major areas which are affected did not show any blooming. But still is likely to be metastasis, since already they found a renal cell carcinoma.
The
Okay.
brisk reflexes on the upper limb, the left upper limb, can be explained only by this, no, sir. If you bring in that radical, evolving GPS also, it will not be explained, no, sir. Like GPS means reflexes should be there. So
Exactly. That's the point. So some of the features, then you ask me, the weak muscle by the reflex should have been brisk. That is not brisk. Triceps is decreased. See, in a person who has been an old man, who has got other comorbid conditions like diabetes or cervical spondylosis, some of the findings may be there, which has been there earlier. For example, absent triceps reflex might have been there earlier. That's why it's absent bilaterally, because spondylotic radiculopathy is very common. So over and above that is develop some signs, so that absent reflex will mask the development of a typical pyramidal signs. This is what is going to happen practically in most of our time when you see in our day-to-day practice. This is what is happening. We don't see a very clean case as we expect in the textbook. Okay.
Sir, the
Sir,
absent
one doubt.
reflexes.
Yeah.
So in a normal person,
Hmm.
the absent reflexes could indicate what? Is it a subclinical motor radiculopathy or something?
No, if suppose an old man has got an absent reflex, if it is exactly symmetrical, bilateral, hefty man, it can be normal for him. Many normal individuals can have a diffusely absent reflex. In an elderly individual, suppose if an upper reflex is bilaterally absent, most likely in subclinical cervical radiculopathy. And to cause reflex loss, it is the posterior root which is compressed, not the anterior root. To cause reflex loss due to an anterior root compression should have been established weakness, because on the other hand, a mild compression of the posterior root can have only selective loss of reflex without any weakness or without any sensory loss.
Okay, sir. Thank you.
Sir, one doubt.
Yeah.
Suppose if that relative had not brought in the diagnosis of renal cell carcinoma,
Yeah.
with this findings, you would have straight away went ahead with the MRI brain and the cervical spine?
No,
Or
that's a good question, because I did not think of a brain lesion initially. My diagnosis was with this developing GPS or mononucleus multiplier. That's the initial thing I had. But again, something was very unhappy. As you are unhappy, I was also unhappy, because that the lesion confined only to the left side was making me odd, and the weakness of predominant thumb involving without any sensory was also odd. So then that's why I think whether to do imaging or not, I was thinking. Then they brought the ET.
okay, sir.
I wouldn't have thought of particularly the very primary way. I'm very frank with you.
I would have taken, I would have ordered Oxford MRI.
Yeah. Right. No, this is not already. That's why I bought this case for the meeting. Now I'll show the another case. I don't know whether I've shown you before or not. It's a short case. 64-year-old diabetic patient came with this paresthesia of the left index finger 1 week back. Along with this, he noticed difficulty in picking up small objects, buttoning the shirt, and occasional dropping of the object. No other complaint. The history was something like a median involvement. So let us see the video. Examine. Right. If history was telling, for those you cannot understand Malayalam, he's telling numbers of the index finger. He said he's got weakness of the thumb and index finger. Unable to put button. You take the glass from the left hand, he may fall down. That's all the story. No other complaint. Okay, now let's see the examination. His opponent was normal on the right side. He is weak on the left side. He could not oppose it, it goes sideways. He couldn't do that. Neurology were normal. That also is okay.
ഓക്കെ ഇനി ഇതിങ്ങനെ ഇരിക്കണേ, ഇങ്ങനെ കേട്ടൊക്കെ സമ്മതിക്കരുതേ.
There is normal on the right side.
ഇത് ഇങ്ങനെ മലത്തി വെച്ചു, ഇതിങ്ങനെ ഇരിക്കണം, ഇങ്ങനെ ഇരിക്കണം. ഇനി പിടിച്ചോ.
It is weak on the left side. Okay, so on examination, it weakens the left opponent's policies and abductor policies babies. No, but even though he combined a paresthesia, there is no sensory loss. So what is your possibility?
It's a cortical thumb, sir, left side.
No, I think that the other people also speak, but now we are, we must have seen this case earlier, so met at other people also. So what do you think now? It's more like a carpal tunnel syndrome. What do you
But,
think?
but sensory loss is not there, no. So
Yeah, sensory extra weakness is that many times carpal tunnel, you don't expect any sensory loss. How many times have you seen sensory loss in carpal tunnel? Yeah.
sensory loss may not be there.
Symptoms,
Numbness will be there, sir.
yeah, paresthesia will be very common. Sensory
Yes.
loss,
It's acute onset in just 1 week. So
but yeah. Okay. So, is there anything odd against carpal tunnel syndrome in this patient? That's the point. You come with the numbness in the index finger and weakness of the opponents and abductor pollicis brevis. Actually, I think will be carpal tunnel.
But we
just
can
2
mark.
muscles involved in acute onset.
Fine. Carpal can be acute onset also.
Just 2 muscles involved in.
Hello, what other muscle you expect on the flexor pollicis brevis that I have not examined? With this, I am happy because we already know that thenar muscle is affected. Introsseous pain.
This sort of acute onset, usually you would think of, you should rule out something else before you diagnose it as CTS.
Okay, correct. So, what will you like to rule out?
That's like Umar said, it should be because just the thumb which is involved.
Okay, correct. So that's what but again, not suspect what you odd again. Many times carpal can be very acute because no, they develop some fever and arthritis and they develop carpal tunnel following that. Following some strenuous, many times when strenuous work in the floor and all, they may be doing some previously some what do you call it, cleaning in the house with the hand, then they develop carpal tunnel syndrome. It can be acute. But in a cortical lesion, the paresthesia of the index finger is very odd. How many cortical lesions have you seen paresthesia of the index finger? Weakness again. Yeah, usually most of the time it is pure motor because the hand of the ASL is affected. But the point is after examination, you not have any numbness, but a complaint of paresthesia. So the real the doubt why examined further was not that thing. That I'll tell later on. If examined further, yes, but adductor pollicis is weak on the left side. Flexor pollicis longus was normal. Good call. Extensor pollicis longus was that is normal on the right side. That is weak on the left side.
ഇത് മാത്രം മുകളിലോട്ടിരിക്കണം മുകളിലോട്ട് പിടിച്ചേ പിടി.
So now we found in further examination is found here weakness of adductor pollicis, extensor pollicis longus in addition. So the muscles affected are APB, Pons pollicis, extensor pollicis, adductor pollicis. Now where is the site of lesion?
Now only cortex can explain.
Exactly. Now only the cortex will come. Perfect. So what will you like to do now?
Neuroimaging.
Oh, you can't straight away go for neuroimaging. You want to have
Nerve
some.
conduction study.
No, I did not do nerve conduction study. What are the bedside tests will you do to find out this connected to be cortical?
Fine finger movements, tapping the.
Very good. Very good. So let us see what I did. So this is the left hand. On the right hand,
ഞാൻ കാണിക്കുന്ന പോലെ ഇങ്ങനെ കാണിച്ചു
with the rapid movement to the right hand. He is doing very fine. See how clumsy it is on the left side? With the normal finger flexion power and finger extensor power, how clumsy the weakness is. Did you see that thing? So that is the real point that this patient is in the cortex. That's called loss of finger dexterity. The normal power is unable to do fast movements. It's considered on the left side. Okay, now we can do the imaging. And this image, as Umar and all suspected, it's likely to be narcotic infarct. But initially, one should not consider because of the paresthesia. Now, what made me think of a cortical lesion initially? Can anyone tell?
Because the extensor pulse is
No, that
easy.
came. So that see, I'll tell you frankly,
Uh,
how many times in the OPD, BC OPD, somebody comes up and says that thing, and they go and examine each and individual. You don't examine. Suspect needs to easily suspect carpal tunnel. Okay, look for any weakness of the thenar muscle. I'll grossly check the finger abduct. Ulnar nerve is not affected. Then we
Without
call
any sensory, sir.
okay. But then
Dropping of objects.
As there is no sensory and not following any territories.
that's up subsequently. So in that only when you examine all the muscle, then picture becomes very clear. But the OPD to suspect, no, you have to examine for the form and sign. You have to examine the extensor pulse longus in the OPD. You have to suspect that from the very beginning. The clue is that he's dropping things from his hand. How many times carpal syndrome they drop things from the hand? They don't. That is the clue which made me suspect that I'm going in the wrong direction. It is not simple carpal syndrome.
Some patients usually complain of dropping, sir, with CTS.
No, they don't complain. No, I've never seen CTS complain dropping other things because in the affection is mainly in the flexor pollicis brevis. Longus is normal. They don't drop the things because other muscles are all normal.
So
I think
what
maybe
about the
because they
cortical
associated
sensation
sensory
here?
also.
Yeah, it is a severe involvement. As you said, is correctly. The severe CTS and sensory loss, they can drop. That's correct. Severe CTS, not a sensory loss. But with a normal sensation, they will not drop.
Sir, I wish
Sir,
to hello, sir. I wish to share one observation.
Yeah.
Like what we did, these sort of spin kinetic movements in upper limbs. In the previous case, the earlier one for foot
Yeah.
drop, cortical foot drop. Can
Yeah.
we do the foot tapping test and
Yes,
to compare it on both the sides and do the similar test?
Perfectly, you're perfectly right. You can do the foot tapping test. In the first patient, I couldn't do the rapid alternating movement rapid fine movement because already the muscles are weak. The finger extensions are so much weak. There's no point in doing the rapid alternating movement. So this loss of dexterity point, the helpfulness all come when the power is relatively normal. Then you get loss of dexterity. Then it only becomes a cortical lesion, become significant. Because otherwise, any weakness will result in loss of dexterity.
So in this case, what about the cortical reflexes? I mean, the cortical sensations in this case?
Normal. Sensation is normal, reflex is normal, no patient, nothing.
And what
Sir,
could be the cause for his sensory symptoms in the left index finger?
The cortical, mostly cortical involvement needs, but that's not common. So I have seen many cases of very infarct, but none of them had any sensory. All of them. This is the first page complaint of paresthesia, no, with sensory loss expected.
Sir, one doubt can I ask, sir?
Yeah, please.
Sir, in case of CTS, when the patient develops motor weakness, if the patient does not have a sensory loss, do we have to think away from a CTS?
Yeah, you can have CTS producing only pure motor involvement. Last 2 weeks back, I had a case, somebody asked, I had shown the case also. I had shown the literature also, the CTS can produce pure motor involvement. The reason is that the motor branch, which supplies the thenar muscle, sometimes take off little proximally before the carpal tunnel, and they go through a separate path underneath the carpal tunnel. So the selective compression may be only for the motor part, you may be spared. You understood? Suppose the branching takes off distally as usually happens, distal to the carpal tunnel, both likely to be involved. Sensory to be more vulnerable than the motor. But sometimes the motor division takes off little proximally and we go through a little different from the sensory part underneath the carpal tunnel.
Okay, sir.
I think I don't know, Umar, which is 2 weeks back, did I show that thing? I forgot. Yeah, 2 weeks back I showed this. I showed the picture also about the median nerve going separately.
So can I ask one question?
Oh, anyone can ask, please, please. You're all-
Sir, it is related to the previous case, renal cell
Yeah.
carcinoma.
Right,
I
please.
couldn't unmute myself at that time.
Please.
I want to ask about the NCV findings. How can we explain those NCV findings of delayed latencies and all?
No, you're perfectly right. That means his patient has been having a subclinical neuropathy in this patient. The diabetic is called diabetic. Diabetic can produce usual pattern is axonal involvement, but they can also have demyelination involvement.
Okay.
Here, the involvement is very mild because the only point of demyelination was the dispersion of the potential. The distal latency was normal, so the velocity itself is normal, but the nerves are not conducting uniformly. Even one fiber is conducting normally, velocity may be normal. But among the fibers, they are conducting differentially. The potential arrives at different times, you get dispersion. So that indicates a mild degree of demyelination, not a very severe involvement.
Okay, sir. Thank you, sir.
Thank you. Okay, then you go to the another case, 54-year-old male, diabetic for 7 years. His complaint started 1 week back as pain in the back of the lumbar region, spreading to the thoracic region. No radiation down the legs. The pain subsided in 3 days' time. 2 days later, patient noticed numbness in the distal part of both lower limbs up to the midshin. Okay, low back pain disappeared, then pain subsided. 2 days later, patient noticed numbness in the distal part of both the lower limbs up to the midshin. This was followed 2 days later by difficulty in lifting up his right leg. No other complaint. This is the patient. Painless are all normal. Upper limb power are normal.
എൻ്റെ വിരലിൽ തൊട്ട് മൂക്കി തൊടണം കറക്റ്റ് തൊടണം കറക്റ്റ് മൂക്കിലായി ആ മതി ഇത് മറ്റൊക്കെ എന്ത് ചെറിയ വയ്ക്കണ്ട അതൊക്കെ ചെയ്താൽ
The lower limb, there is mild wasting of both thigh. Even the duration is 1 week, wasting of both thigh was there. Bone was normal.
അച്ഛൻ അങ്ങനെ കൈ നെഞ്ചിച്ച് വെച്ചിട്ട് എഴുന്നേക്കാൻ നോക്കി എന്ന് ചെയ്ത് നോക്കി
He was not able to get up from diagonal position.
ഇനി ഈ കാലം ഇനി ഇവിടെ പിടിച്ചോ എടുത്തിട്ട് ഈ കാലം ഇങ്ങനെ പൊക്കി
Left hip flexion on the left side is normal.
പിടിച്ചോ പിടിച്ചോ പിടിച്ചേ ഒന്നുകൂടെ പിടിച്ചേ ഇത് മതി ഇത് പൊക്കാൻ ശ്രമിച്ചേ.
On the right side, it cannot lift it at all. This just barely lift up against gravity, about 3 to 3 plus. The extension was normal on the left side. Right side, it is severely weak. He could not extend. He's a hefty man. He could not extend it. Adduction was normal bilaterally. Hip abduction was also normal.
കീഴോട് തള്ളിപ്പിടിക്കുക അതായത് ഞാൻ പൊക്കാൻ സമ്മതിക്കരുത് തള്ളിക്കോ
Hip extension was normal.
അതേമാതിരി തള്ളിപ്പിടിക്കുക മതി വിട്ടോ 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 ഈ കാര്യം മടക്കിക്കും മടക്കി മടക്കി അങ്ങ് പിടിക്കണം ഊർക്കാൻ സമ്മതിക്കരുത് വിട്ടോ വിട്ടോ
Hip flexion normal.
ഇത് മടക്കിക്കേ മടക്കി അങ്ങ് പിടിച്ചോ മതി വിട്ടേ വിട്ടേ മുകളിലോട്ട് ഇതോട്ടൊക്കെ അങ്ങനെ പിടിച്ചോ ഇതും പിടിച്ചോ
First flexion normal, EHL normal.
കീഴോട്ട് മടക്കിക്കേ മടക്കി ഇത് മടക്കിക്കേ ഇതകത്തോട്ട് പിടിച്ച് ഇങ്ങനെ പിടിച്ച് ഇതിങ്ങനെ പിടിച്ച് ഇനി വിട്ടോ 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 ഇങ്ങനെ ഇരിക്കണം ഇതിങ്ങനെ ഇങ്ങനെ ഇരിക്കണം ഇത് പിടിച്ച് കേട്ടോ.
Reflexes, biceps supinated just visitable. 1 plus. Both biceps were absent.
ഞാൻ പറയുമ്പോൾ കൈ മുറുക്കി പിടിക്കണേ. വലത്തെ കൈ മുറുക്കി പിടിച്ച് പിടിക്കണേ.
It's also bilateral.
വലത്തെ കൈ മുറുക്കി പിടിച്ചേ.
Indication is also absent. Abdominal reflex intact.
ഞാൻ പറയുമ്പോൾ കൈ മുറുക്കി
Both knee and
കൈ
ankle
മുറുക്കി
were absent.
പിടിച്ചേ. വിട്ടേ, ഒന്നുകൂടെ മുറുക്കിക്കേ. കൈ മുറുക്കി പിടിച്ചേ. കിട്ടോ, മുറുക്കി പിടിച്ചേ.
As flexor. Sensory normal except for the impairment distally, which are all normal. Lower limb normal, the thigh region.
ഇനി ശ്രദ്ധിച്ചോ, ഞാനിങ്ങനെ കുത്തി വരുമ്പോഴേ ഈ കുത്തി ഇങ്ങനെ മുകളോട്ട് വരുമ്പോൾ ഇതെല്ലാം ഒരേപോലെ അറിയാവുമെന്ന് പറയാം. അറിയാമല്ലോ, വ്യത്യാസം അറിയാം.
It's normal, no difference in the pain for distally and proximity.
ഒരേപോലെ ആണല്ലോ, രണ്ടും ഒരേപോലെ ആണല്ലോ. ശരി, വെരി ഗുഡ്. ഇപ്പോൾ ഉണ്ടല്ലോ,
Normal upper limb.
ഇപ്പോഴോ
Over the toes it is diminished.
ഇപ്പോഴേ ഇല്ലെന്ന് പറഞ്ഞാലും മതി.
There it decreased.
ഇപ്പോഴോ ഇപ്പോഴേ അതിനോട് ചെറുതായിട്ട് ഇപ്പോഴേ
Upper limb normal.
ഇപ്പോഴേ അതേ എനിക്ക് നോക്കരുത്, ഞാൻ ആക്കുവേ. അറിഞ്ഞോടെങ്കിൽ അറിഞ്ഞോണെന്ന് പറഞ്ഞാലും മതി. ഇപ്പം എങ്ങനെയാ?
It's not able to breathe. Okay.
ഇപ്പോഴേ ഇപ്പോഴേ
It's impaired.
ഇപ്പോഴേ
They were to save time itself, fast forward. The gait of the patient is normal. Complex, very mildly positive. He can get a sitting position. Okay, this is the finding. In Tendelberg test was negative. There is no problem. Okay. So examination, kindness normal, upper limbs normal, lower limb wasting of both thigh, right more than the left. Grade 3 plus power of the right hip flexors, left side Corey, not very convincing. Knee extension is weak on the right side. Left side is normal. The rest of all muscles are normal. ATR, biceps supinated normal bilaterally. Triceps pain production absent. Lower limb, both knee and ankle jacks were absent. Flexor bilaterally. Sensation, impaired vibration, JPS over both toes. So where do you think is the site of lesion and what is the
could you just show the history just a second? History only.
History. I'll tell you. Just one minute. This is the 60-year-old man, diabetic man. Combine started 1 week back as pain in the back of the lumbar region, spreading the lower thoracic region. There's no radiation down the legs. The pain subsided. 2 days after the subsidence of the pain, he developed numbness of the distal part of both lower limb up to the midshin, paresthesia. This was followed 2 days later by difficulty in lifting up his right leg. In fact, his main complaint was he is not able to lift up his right thigh. That is his complaint became. Okay. So, anyone would like to make a comment? Sir? There is a site of lesion.
The bilateral lumbar plexopathy more on the right and bilateral peripheral neuropathy.
Okay. Plexopathy. He had no pain. Weakness was only on the right side, not on the left side.
Yeah, he has wasting of the left thigh. No?
Wasting, how long it had been there earlier, we don't know. because even with 1 week involvement, right side also said like can produce wasting out uncommon. With 1 week wasting developing is little odd. But the weakness was mainly on the right side.
So is he able to get her from the square?
He is able to get it from the squatting position. I did not try. I did try only for this tool that he could do. Showing that he's got a good power of the hip extensors, good power of the knee flexors, hip adductors. The weakness is confined to the right hip flexion and right knee extension. Any other person?
L1, L2, radicals, L1, L2.
Radiculopathy could be, but it's only motor radiculopathy. You have to keep that possibility. That possibility can be ruled out.
He has peripheral neuropathy as well as he probably has a predominant plexopathy more on the right side because the hip flexion and the knee extensions are equally weak. So that has to implicate either a femoral nerve or a proximal, lumbar radiculoplexopathy.
Again, just like told before, no, in a person with coming to OPD in a short duration, the short duration of weakness of one limb. So we can't straight away say what is going to develop in next few days' time. It's only 2 days back he developed this weakness. Suppose tomorrow he's going to develop weakness of left lower limb. Day after tomorrow they are going to develop weakness of the upper limb. Then the picture changes, no? So you have to keep a broad idea should be kept in mind. So first possibility, agree with you, should be a plexopathy, the neuropathy. Again, remember that paresthesia also developed only 2 weeks back. It was not there earlier.
The possibilities is spinal cord lesion because he had sensory symptoms in both his legs ascending up and.
But that's odd with everything is element. There's no human finding. You mean to say the lesion in the epicornus region, no?
Yeah, the bilateral sensory, some numbness or paresthesia of both his lower limbs.
Yeah, he had, that is his complaint also bilateral numbness. Again, came only 1 week back. Okay, so that means I'm not sure it's going to develop GBS in this patient also. It's original GBS. With the findings, most likely plexopathy. So what do you want to do now? And he was not at all willing for any MRI because he's so much claustrophobic. So I wanted to get after doing the NCV and all, but I sedated him, took him to the MRI institute again. He could not tolerate. So I dropped that idea.
Sir, how can we explain this triceps and finger flexor absence?
Yeah, that just like told before, no, many normal individual, in old individual, you can have absent triceps flex, or all reflex may be sometimes absent because they can have subclinical involvement radical due to cerebral spondylosis. That is very common phenomenon which you come across. Suppose he has got findings like sensory motor in that distribution, that should be given significance. But as you said, suppose he's who can say he's not going to develop weakness of the triceps tomorrow? The reflex maybe the initial finding. You're right. That way you're right. At this present time, but I do not know whether it's going to develop GBS tomorrow or not. Because maybe reflex loss in the upper limb. But I have not seen him earlier. But the wasting is odd for a GBS.
Yes.
Again, you have to think that wasting might have been present earlier. We don't know what happened earlier. See, if it is telling that sir, my thigh got thin now, then it's become different. So many findings may be there before which we have not seen the patient earlier. So you have to keep a little broad data you have to keep in the back of the mind. But most logical you have to keep in mind. The most logically is likely to be plexopathy is the current finding. Okay. So what do you want to do? Nerve conduction. Okay. You don't want nerve conduction?
Yes, sir, we want.
Okay. So you see the nerve conduction now. Right peroneal, left peroneal, low amplitude. And the velocity, look at the velocity, all lower range. 33, 31, 37, 32, like that. Now, The median, of course, this median you can ignore because it is all carpal tunnel. Maybe many of them have undetected carpal tunnel. But look at the sensory. All, even the left median, the amplitude, that's for the carpal tunnel, where all the sensory potentials were absent. Supraperoneal was absent, sural was absent, saphenous was absent. And look at the FA, all FAs are prolonged. Even in the upper limb, with the normal ulnar nerve, the FA latency is prolonged. Now, what do you want to do now?
Yes.
Yes, sir. Protein 58, sugar 152, cell 1 cell. What do you want to do?
So what is blood sugar? Sugar, what is the blood sugar?
Blood sugar is a diabetic, no? And it's a CSF become high because of my treatment also. Yeah. So what do you like to do as a practicing neurologist? This is a situation.
Methylprednisolone, sir.
Okay. Why you still want to keep prexopathy as a possibility rather than developing ABS? FAS are all prolonged.
Because the all the snap is absent in the lower limbs as well in the upper limb. So that is not a typical feature of a Guillain-Barré.
No. The point is, I'll tell you, I'll go back to the, this is the point. See, in the upper limbs, where the distal latency was normal, when the CMF was normal, is FA is prolonged. The earliest evidence of GPS is prolonged FA latency before anything comes. The lower limb snap absent, etc., could have been due to unrelated neuropathy that we cannot say. But why FA should be prolonged in a person with a normal distal latency, a normal snap in the upper limb? That means it cannot be explained by a peripheral neuropathy in the upper limb. Okay. So
but the wasting is slightly odd for a Guillain-Barré, right, sir?
Yeah, correct. But we don't know how long. Just like what I said, we don't know how long it has been there earlier, and you don't expect a wasting to occur in 1 week's time in a plexopathy.
MRI.
MRI can't be done.
So then IVAG.
IVR. That's ideal thing is IVAG because it will strike both. Whatever it is, but I couldn't afford IVAG.
Because his pain subsided, the usual history, pain subsiding and then the weakness starting is usual for a plexopathy. If it's due to GBS, usually the pain would persist.
Yeah, that's one point, but the pain was not at all in the thigh. He had pain in the back, lower back, and the pain subsided. Then developed the weakness of the right thigh. He had no pain in the right thigh.
Backache can occur in the Guillain-Barré, right, sir?
Yeah, it can occur in Guillain-Barré. It can.
So we can't definitely differentiate Guillain-Barré from that.
Backache can occur in Guillain-Barré syndrome, and sometimes they can be severe backache and something like a radicular pain they can have. Limb can have GBS. The point is that still, no, what I did was, as you said, I put the patient IV methylprednisolone. The reason why I put the methylprednisolone was that his weakness was confined only to those two muscles. But even though the conduction was slightly off, favoring GPS, the CSF protein was also normal, which may not be abnormal when you do the CSF within 1 week. So all points are little, the other way and this way and the other way around. So I you put the patient in methylprednisolone and wait and watch the patient whether developing weakness or not. He did not progress further at all. In fact, after 5 days, he had mild improvement in the weakness. At the time of discharge, the weakness is not much improved, but mildly he is able to lift up the right load. So has to come for follow-up after 2 weeks. So this sometimes cases can be very tricky. The clinical and electrophysiological finding may not go together. So in that case, I always weigh clinical finding as my deciding factor rather than any other investigation. And this pattern is typical of a femoral neuropathy because of the hip flexion weakness and knee extension weakness. All of the muscles that it's confined to that particular nerve. The other adductors are spared, extensors are spared. So that's a one type of a diabetic ametraphy.
Knee extension was weak, sir.
And knee extension was weak, severely weak. Hip flexion.
Knee flexion also on one side.
Normal. Knee flexion is normal. Hip extension is normal. I checked each and every end. See, Trendelenburg was normal. Hip abduction is perfect.
Sir, femoral nerve conduction.
Femoral nerve conduction was, I advise that. I don't know whether it's present or not. Femoral nerve, I did. Saphenous was nerve, not femoral amplitude, but that's many a time not going to help at all.
The femoral nerve conduction
is here, femoral. I did that. That is not.
Sir, can there be a predominant motor involvement in the femoral nerve?
Yeah, correct. That's what is happening in plexopathy. In plexopathy, in femoral neuropathy is number. See, just like brachial neuropathy affecting the upper limb, that is predominantly motor involvement. And the motor involvement may be confined only to one nerve distribution or multiple nerve distribution. Sometimes, as discussed earlier, neurologic ametraphy can be confined only to the anterior dorsal nerve. It can only be confined to the long thoracic nerve producing swinging of the scapula. It can only be confined to the diaphragm. So these are all well-known manifestations of diabetic ametraphy, plexopathies. Just like that, it is confined only to the femoral nerve distribution. That is the point. We should make a suspect more take a plexopathy rather than a developing GBS, even though their condition was showing some prolonged defibrillation.
What about the sensory symptoms ascending from the legs to the mid shin? Was it a part of the plexopathy or?
No, that's little odd for me. That's not a part of plexopathy. That should, if it has been there earlier, that could have been thought of neuropathy. But unfortunately, this patient had, it got along with that, just 2 weeks back. Your point is well taken, perfectly. That is the thing, the case become very tricky. What you said is correct. If you get paresthesia 2 weeks and developing weakness, one should naturally think of it GBS developing. That's the usual pattern which we all see.
So that may be part of a hyperglycemia, sir. Hyperglycemia induced peripheral neuropathy.
No, occurred after my treatment. Because this eosinophilic went up because it became 400 after starting IV methylprednisolone. Prior to that, it's only mild elevation. It was relatively maintained on oral hyperglycemic drugs. Okay.
So what is the follow of the patient?
Follow up surgery only to. I kept him in the ward for 1 week.
Okay.
He did not progress. He improved it. Why I kept him in the ward for 1 week? Because I was fearing whether he may progress to developing worsening of the knee. He did not progress at all. We can confine only to that muscle, 2 muscles, even at the end of 1 week. That makes GBS very unlikely.
Okay. MRI of the plexus would have helped us, sir?
Yeah, but MRI, that's what I had in mind. MRI the plexus I wanted to do, but the problem he could not afford to. It was so almost claustrophobic that we could do the MRI.
It would have differentiated between the plexus and the GBS root involvement.
No, the problem is that even in lumbar plexopathy or a neurobrachial plexopathy, many a time MRI is normal. MRI plexus is normal. Only if you are able to find some enhancement or thickening, we would be lucky. But most of the time they are normal. You have to go by clinically only. The idea of doing an MRI is not only the plexopathy, rule out radiculopathy in such situation.
Yes.
Yeah, that's the idea of doing MRI because we want to rule out a disc prolapse or something, mimicking a plexopathy.
Right, right.
And the other idea is to look for any infiltrating lesion in the plexus. Suppose you've got a severe pain and all, you may find some malignancy infiltrating the plexus, in the pelvic plexus, or in the there MRI is useful.
Yes.
That's MRI is useful. But the usual, the urinary garden MRI in neurologic ametraphy, MRI most of the time is not.
Yes. So one more question.
Yeah.
Sir, in plexopathy as well as in Guillain-Barré, the contrast can still show enhancement of the plexus. I mean, the root, sir. Isn't it?
If you is confined only to the plexus, it is likely to be a plexopathy only. Suppose you got this patient enhancement confined to the lumbar plexus, it's like plexopathy rather than a GBS. In
Yes,
GBS,
sir.
if at all, you expect to be diffuse involvement. And
Yes, sir.
again, usually they are described only on CADP, not in acute AADP. In chronic, then only you find this kind of enhancement.
Okay.
So you have put him on steroids long term? Like
No.
how long?
No. Usually diabetic amyotrophy put only short course. You would 3 days or 5 days. That's enough for them. They develop much improvement subsequently. You not go on putting continuous steroid.
So what about a severe painful diabetic radiculoneuropathy in well-controlled diabetic patients?
Okay.
If they're not getting controlled by all our medications like gabapentin or is there any indication of steroids in that patients?
That is the indication of steroid. In severe painful lumbar radical plexopathy, you put the patient on steroid. I can tell you next day the pain will come. Next day the pain will subside or come down remarkably. They'll be crying with pain with any amount of gabapentin, amitriptyline, lacosamide. Next day starts steroid relief.
So do we need to put them on a long-term oral
You don't
steroids or
need-
admit them and give
you only put them on 3 days. Measured 3 days and 500 milligrams is enough. 3 days they improve. This may I have seen. I've been giving it this statement for many years now.
Okay. Okay, sir. Fine. Thank you, sir.
So I think we'll stop here because 10:30 there's another master class. So okay, thank you all listening.
Thank you, sir.
Till we
Thank you
meet.
very much, sir.
Thank you.
Thank you
you,
very
sir.
much, sir. Good day.
Thank you, sir.
Good day. Thank you. Good day. Good day.
Thank you, sir.
Thank you. Thank you.